the atrium. An increase in
Blood?
venous return, exactly. So they release atrial natriuretic peptide, which works back to the kidneys again, and decreases sodium reabsorption. So there's going to be more sodium in your urine. Because of more sodium in your urine, there's going to be more water in your urine. So you're going to have a greater urine output, which means less water is being reabsorbed to the body, which means decreased blood volume, decreased venous return, decreased end-diastolic volume, which is the whole reason we're doing this, because we had too much end-diastolic volume to begin with, right? So this is the only, of the chemicals we've listed, this is the only one that's going to lower venous return. Okay, we have about 20 minutes. So the new material here are the factors that affect peripheral resistance. Okay, blood diameter, blood viscosity, and vessel length. It's really the only new material. We talk around these chemicals. And hopefully it's not like 500 minutes of, yeah. So, let's look at some review slides here. And this covers a lot, so let's have some fun. I didn't bring any candy, but. All right. So posterior surface of the heart is formed by which of the following chambers? Left atrium. Part of the left ventricle, because 2/3 of the left ventricle is posterior. Sorry, am I right here? So 2/3 of the ventricle is posterior, but almost all of, well, actually all of the left atrium is, except for the auricle. Okay, so the auricle we can see from the anterior view as well. All right. All right, which of the following would function to increase blood pressure? Here's these terms again. So an adrenergic agonist is going to do what?
Simulate the adrenal system.
All right, so it's going to act just like norepinephrine. It's going to bind to the same receptor as, it's almost like a sympathetomimetic. It's going to bind to the same receptor, the beta-1 receptor on the heart. So it's going to increase heart rate. If it binds to the ventricles, it's going to increase contractile force. So for both of those, what about blood vessels? If it binds to alpha receptors, it will cause them to constrict. So remember, we're looking at both aspects. Cholinergic blocker. What does that do?
It's going to lower heart rate, or increase heart rate.
All right, so it will block to the same receptor as acetylcholine, but it won't have the same effect. It will keep acetylcholine from blocking to it, from binding to it, and therefore it allows sympathetic to act. So it's going to do, it would also increase. MAO inhibitors, we don't usually use these for heart disease, but they can have heart side effects. So MAO inhibitors are used for psychiatric issues, and MAO is monoamine oxidase, which inhibits the breakdown of what neurotransmitter?
Epinephrine and norepinephrine.
Norepinephrine. So if we're inhibiting the breakdown of norepinephrine, it's also serotonin, but norepinephrine is a monoamine, then we're going to end up with more norepinephrine in the synaptic cleft. So it's like giving somebody more norepinephrine. Cholinergic agonist.
That works with parasympathetic.
So that's going to increase parasympathetic effect, so it would not be increased blood pressure. What about acetylcholinesterase? Okay. Yeah, it increases, it breaks down acetylcholine. So it's similar to a blocker, except instead of preventing it from binding to the receptor, it just breaks it down. It makes less acetylcholine at any given time available for the receptor. Okay? And cocaine increases the amount of norepinephrine in the synaptic cleft as well. All right, which of the following function to increase venous return? Ventricular fibrillation?
No.
No. because that inhibits, we end up with no stroke volume, because we're not having ventricular contraction, right? All right, exercise?
Yes.
Yes, because of our skeletal pump. Atrial natriuretic hormone release? No. Increased cardiac output?
Yes.
Yes. Aldosterone?
Yes.
Yes. Diuretics?
No.
No, because we're decreasing blood volume. And the Valsalva maneuver is that decreasing, pushing your diaphragm up and pulling your ribs down and breathing out as hard as you can without opening any respiratory passageways. So that increases intrathoracic pressure.
It's gonna
Would that increase venous return?
That'll decrease.
No, it would decrease it, okay? All right, so exercise, increased cardiac output on aldosterone release. All right. Which of the following happens at the end of isovolumetric relaxation? So visualize that graph. I'll show it to you in just a moment. So at the end of isovolumetric relaxation, are we at the P, the QRS, or the T wave? The T wave, okay? So beginning of ventricular ejection,
No.
filling,
Yes.
all right? Aortic valve closes or opens?
It's already closed.
Closes.
Closes, because we're coming down to relaxation, which is so it's, at the end of relaxation, it's already closed, you're right. So at the end of relaxation, it's already closed. And ventricular pressure is lower than aortic. So at the end of isovolumetric relaxation, if I had something else out there to put up, I would put AV valves open.
So contraction is when they're both closed? And
They're both closed, isovolumetric is they're both closed.
Okay, and then.
In contraction, the ventricles are contracting, so that happens at the beginning of the QRS wave. Then relaxation, we're at the T wave, and the ventricles are relaxing, but the valves are still closed because pressure hasn't yet dropped. All right, so this right here is isovolumetric relaxation. So at the end, we're right down here.
And then they open.
Okay, the ECG strip below illustrates a slowing of the conductance of the impulse through the ventricular contractor cells. And, it should say ANDA. So down here,
You get a wide QRS.
What are you asking?
now which of these events is occurring? It should say, and indicates a slowing, and which of these do we see? So this is a normal, and
Is it D? E? I don't know. E?
do we see a widening of the QRS? There's also a peaking of the T wave. But the reason, I mean, all of these are occurring, but this is the one that's associated with the slowing of the conductance. So it takes longer for that conductance to pass through from one ventricle to the next. And so that is what results in a widening of the QRS wave. The peaking of the T wave is because repolarization occurs more quickly. So the enlarged P wave shown here in red, it would be due to which of the following?
Something with the H.
C.
P wave
No, it's not
occurs
gonna be in the
because
next
of
AV nova blockage.
atrial depolarization.
So is it
So the enlarged P wave, A,
a large left?
takes longer for the wave of depolarization to pass through the P wave, the atria. So our P wave becomes enlarged because that's a factor of time. All right, so in this one, what do we see that's abnormal? There you go. Elevated ST. So the S is way up here, and the first part of the T is up high as well, and that's characteristic of heart attack, the damaged contractile cells. So here we're seeing what?
Disassociation of the Q wave.
PR?
So here's our P,
T doesn't
here's
look
our
like it.
P. Here we have a P without a QRS.
Where's T?
Here's another P. T's right here.
Oh, The T looks weird.
So it's irregular PR interval due to AV nodal block. I gave you the answer there already. All right, in fetal circulation, right and left ventricles pump the same stroke volume, is that true? Unless the fetus has congestive heart failure, it does. All right, right and left ventricles pump the same stroke pressure.
Yeah.
How do we know? So you're gonna have to figure out this answer. I don't-
Remember, the pulmonary system is higher in the fetus, which is why we redirect the flow from the pulmonary trunk into the aorta. So the ductus arteriosus, blood that's already in the aorta, goes into that's already in the pulmonary artery, goes into the aorta through the ductus arteriosus because pressure is higher in the lungs than it is in the systemic system.
It increases blood pressure, which
The monoamine oxidase inhibitor, if it increases the amount of what neurotransmitter? Norepinephrine. If we have more epinephrine, which of these things going to happen? Increase heart rate. What about calcium ions?
Yeah.
I
Yes.
don't know.
Remember, I just showed you, it opens up the plasma membrane as well as SR channels. Increases heart rate. Would there be a prolonged PR interval?
No.
I don't know.
No.
And with the A and B, we're going to have an increase in stroke volume. Okay? So again, this is not, once you understand the basic facts, these are things that you can kind of think through and figure out rather than have to instantly know the answer to each one. You go back to what you've already covered. All right, which of the following events, I'm going to give you the answer already.
Wait.
So which of the following events are going to occur during one?
One. Before. Oh, you're asking.
I already told you, current passing through AV nodes is 4.
Okay.
Atrioventricular valves are open or may be open. Is that true?
Yeah.
At 1? That should actually, at the end of 1, AV valves are going to open, so I don't like that answer.
Oh,
But yes, ventral ejection shows semilunar, both of this is going to close. This is still, so no, it's not B. Ventricular ejection is slowing down.
okay.
The dichrotic notch would appear. Are the funny channels open?
Bipolar, well, after.
Not yet.
Yeah.
So what happens? Here's our P wave. SA node is fired, that's why we get the P wave, right?
Uh-huh.
And that action potential occurs, and then this entire time, funny channels are open until we get to threshold and another P wave. So the slow calcium, so remember when we looked at, so here, we would have just had an action potential in our autorhythmic cells. And then this entire time, we're reaching, or increasing our graded potential in the autorhythmic cells, and we'll reach threshold just before the P wave. So those cells are going to be open there.
Do they ever close then?
Yeah. Well, they close when the polarity, they close when, just before the transient channel's open.
So right before depolarization?
Uh-huh. Which of the following events is occurring just prior to 3, so at the end of 2?
Ventricular filling, I know something like that. AV valves are open.
Okay, so the AV valves would be open.
Not C.
So just prior, our fast calcium channels are going to open because that's what creates the SA node firing that allows us to have P. So atrioventricular valves are open. What about semilunar valves?
No, they're not.
Not yet.
Okay, so they're not open, and funny channels in the AV autorhythmic cells are open, but in here they close because we've just reached action potential. But this time we're in the action potential. So we're no longer in this one. In the previous slide, we were still getting to the threshold. Once just prior to P, we're at the action potential. I want to move ahead here to these we've covered. All right, down at the bottom, hopefully you can see it. We have different types of membrane potentials, all right? So identify what type of channel and membrane potential do we have at A?
Action potential with the fast acting calcium.
Depolarization. What do you want? Oh,
It's all
that.
So we have a long-lasting fast voltage gated channels, okay? B,
Potassium channels,
potassium channels. C,
Sodium.
sodium,
Depolarization.
are
fast
they
acting.
voltage gated?
Yeah.
Yes,
Okay, action or graded?
action,
Great potential. Great, it's like down.
So it's an action potential. D,
that's calcium and potassium.
calcium and potassium, right here at the beginning, it's just calcium, and then we pick up potassium here. And there's two different kinds of
slow
potassium, but I'm not
acting?
getting into
Oh,
that, so I probably, so there you go.
Okay. Slow depolarization.
E,
That's
Depolarization.
potassium.
Just potassium.
Voltage.
okay, F,
Action
skeletal
potential.
muscle cell.
Oh, is that
Sodium.
sodium?
Sodium.
Oh, sodium.
Sodium depolarization.
Okay, G,
Potassium.
Potassium again.
Polarization.
H is
Graded
here.
Graded
potential.
potential,
Bottom
Graded
row.
potential.
Is
sodium,
that from leak? Oh,
So
ligand.
ligand gated, that's not long, but ligand gated sodium typically in a skeletal muscle. I, that's the resting membrane potential in the
Leak
contractile cells.
Oh, so it's leak.
So we have everything contributing to our resting membrane potential. J,
Funny channel, big time is leak.
okay, funny channel,
Sodium.
yeah. And K,
same
Oh,
thing.
transient.
transient.
Voltage gated, or not, yeah.
Okay, I wanna, we're running out of time here, so these you have practice on in your, so here we go.
Do you have this on the mic?
No?
No.
All right, so superior vena cava is formed by the union of
The brachiocephalic veins,
brachiocephalic.
Yeah.
The popliteal vein is formed by the union of,
the posterior tibial and the anterior tibial.
uh-huh,
The popliteal.
what's formed by anterior and posterior.
Mhm.
Small saphenous drains into it after it's already formed. So three vessels do everything into it. Superior adrenal artery is a branch of,
The phrenic artery,
which one?
phrenic, inferior.
Inferior phrenic,
Oh, yeah. Ooh, left.
okay. Three branches of the celiac trunk,
Splenic.
Splenic,
Splenic,
hepatic,
left
gastric.
gastric, and hepatic. Cephalic vein and basilic vein will drain into the
Axillary.
axillary. Inferior rectal drains into the
Pudendal.
internal pudendal. The portal vein is formed by the union of the,
Superior mesenteric and the splenic.
uh-huh. The palmar arch is supplied primarily by
The radial,
radial.
Okay.
Hepatic artery is found with the
Portal? Oh, wait.
the
Oh.
hepatic vein. Portal vein.
Hepatic artery? Portal vein?
Remember, hepatic veins come out the top of the liver, going into the liver, flowing the same direction. We have hepatic artery and portal vein.
Posterior to
The
the.
pituitary artery is a branch of
Posterior tibialis.
posterior tibial. Dorsalis pedis vein drains into
Anterior.
Anterior.
anterior tibial.
Or greenspan? Oh.
And depends on where we are in it, because it's superficial. Lateral aspect of the foot,
Lateral.
an ankle. If it's superficial, it would be the
Lesser sphincter.
lesser saphenous. If it's deep,
The,
Great sap?
no, the posterior tibial.
The lateral aspect of the ankle is
what's
great.
the lateral bone of the leg?
The fibular.
The fibular vein.
Oh.
Okay, so super deep would be fibular vein. And, all right, I do want to do this. So, remember I said that you would have a table like this on your lecture exam?
I don't.
So a decrease in cyclic AMP is going to do what to the number of funny channels?
It's going to decrease them.
An increase in cyclic AMP will do what to the membrane potential? This is,
Increase it.
so it's going to make it more positive or less positive? More positive. which I don't know how I wrote this, but it's kind of tricky. If it makes it more positive, it ends up decreasing resting membrane potential, because it brings the difference between the two closer. So again, I don't remember how this was, but it makes it more positive. So I'll have to make sure I make that clear. An increase in aldosterone, increases venous return, an increase in end-diastolic volume,
Decreases.
decrease because of Starling's law, and, well,
No change.
unless there's Starling law, there should be no change. But if there's an increase in sympathetic, there would be a decrease. The Starling law, remember, brings it back to its normal volume if we look at the graph. Increase in PR interval.
What's the longer time? Oh, increase.
Because there's a longer time for filling.
Um,
So if you have a decrease in PR interval, you'll have a heart contraction, but you may not have any change in blood pressure because there'll be so little blood in there. But even though you might hear the heartbeat, there's very little volume going out. Increase in norepinephrine, increase in intracellular calcium ions, and an increase in intracellular calcium ions
Increases.
is going to increase cardiac output because it increases contractility. A decrease in acetylcholine,
Increases.
we look at calcium ions directly, there should be no effect. Remember, if we look at, because of the relaxation, indirectly there's an increase in filling. But directly there's no effect on contractility because it doesn't affect the ventricles. A decrease in stroke volume and an increase in heart rate,
No change.
no change, if it's the same. An increase in digitalis, the calcium ions. So we give digitalis to people that have congestive heart failure.
It's going to decrease.
So we want it for congestive heart failure, we need to increase the force of their
So
contraction.
increase.
It's going to increase. Decrease in the viscosity of blood, so it's thicker.
It's going to decrease.
Increase.
Increase.
Or decrease.
No, decrease in viscosity, I'm sorry, I read it as an increase. So a decrease in viscosity means it's thinner.
Right.
So there'll be a decrease in peripheral resistance. An increase in extracellular potassium ions.
It's going to decrease.
Okay, if you want to stay just a few minutes longer, you're welcome to leave because we're done with class.
Can we take a
Trace
picture
the
of
drop,
that?
pardon?
Can I take a
Yeah.
picture?
Oh, yeah. Yeah. Okay, so you're welcome to leave. The last slide is going through a practice blood tracing. So we trace a drop of blood from the opening of the rectum to the occipital lobe of the brain.
Oh, wow.
So we start at the external anal sphincter, and the blood, are we going to veins or arteries here?
Vein.
Veins.
So the
So
inferior.
inferior rectal vein.
To the,
Middle rectal vein?
no, to the
The anus would be inferior. And inferior rectum is going to drain into
the internal pudendal.
internal pudendal.
The
And then left
internal
Internal
iliac.
iliac.
Internal pudendal will drain into
Internal
Internal
iliac.
iliac.
internal iliac, which then goes to common iliac.
Lesser.
So what's between common
Inferior.
iliac and the heart?
Inferior
Inferior.
Inferior vena cava.
Inferior.
And we go through the heart, and the lungs can come back again. So
Okay.
what's the first vessel that we are in leaving the heart?
Ascending the aorta.
Ascending aorta,
Arch of the aorta.
arch of the aorta. And we're going to the occipital lobe, so we're going to take the brachiocephalic trunk.
So
Okay,
the
so we're
vertebral
going to go
arteries.
some places.
So coming off the brachiocephalic trunk, we have a choice.
Right.
We can go common carotid,
Oh.
or we could go subclavian. All right, so looking down through here, where are we going to?
Oh, the
Yeah.
internal.
Occipital lobe.
Occipital lobe. So how are we gonna, would it be better to go take the internal carotid or the vertebral to get to the occipital lobe.
Oh, vertebral. How do we get to, oh, the vertebral then, because we gotta get the posterior
We
communicating.
have to get to posterior, so unless we go through the circuit and, go backwards, best flow is through vertebral, but I didn't do this way.
Oh, man.
Notice what I have here?
Posterior communicating.
Posterior communicating.
Oh, so we
So-
can get to that through the. and so
That's
the
your
internal-
clue here. We are going to occipital lobe, but would we need posterior communicating if we were doing vertebral?
No,
So I put posterior communicating in there as a clue that we're going a different way. So common carotid,
To
Internal.
carotid.
internal carotid,
to middle
What?
cerebral,
Oh, well, yeah, we'll hit that.
Mhm.
And then posterior
to
communicating.
posterior communicating,
to the posterior cerebral.
to posterior cerebral. All right, so I put those answers in there to give you clues, help you along the way, make sure you're going the right way. All
Okay.
right, so posterior communicating, you wouldn't need that if you were going vertebral, because you would just go vertebral to basilar to posterior cerebral.
Okay. Oh, else you'd be going backwards, right?
Yeah.
You were.